Welcome to Mission Evolution Radio Show with Gwilda Wiyaka, bringing together today's leading experts to uncover ever-deepening spiritual truths and the latest scientific developments in support of the evolution of humankind. For more information on Mission Evolution Radio with Gwilda Wiyaka, visit www.missionevolution.org. And now, here's the host of Mission Evolution, Miss Gwilda Wiyaka.
We're in the middle of an opioid crisis. At this point, many doctors are afraid to prescribe opioids, even for those patients with legitimate, extreme pain. If you're suffering from too much pain, what are your alternatives when opioids are no longer an option? Mission Evolution Radio TV show is coming to you around the world on the X Zone Broadcast Network, xzbn.net. With us this hour to explore alternatives to opioids when faced with too much pain is Dr. Andrea Furlan. Dr. Furlan is a physician in Toronto, Canada, a professor of medicine at the University of Toronto, and staff physician at the Toronto Rehabilitation Institute. She's a specialist in chronic pain, and her passion is to teach other physicians, her patients, and the public in general. Dr. Furlan is the author of 8 Steps to Conquer Chronic Pain, a doctor's guide to lifelong relief. Her website, drandreafurlan.com. Dr. Furlan, thanks for joining us on Mission Evolution.
Today, it's my pleasure to be in your show and talk about my favorite topic, which is pain and how to get rid of pain.
Well, I like the how to get rid of part for sure. What drew you to specializing in pain?
Well, when I was a kid, I always wanted to be a doctor. That's what my mom and my grandmother said. And when I was a teenager, I had a lot of menstrual cramps, very debilitating, hard to treat. So I found that pain is kind of dehumanizing because I couldn't do everything I wanted. And then when I went to medical school, I got into medical school, I was, kind of deciding what specialty to do. And I chose physical medicine, rehabilitation, physiatry, because that is a specialty that can see the person with pain as a whole person, because it's a specialty of the person with disabilities. And I find that chronic pains or pain, but especially chronic pain, is more like an invisible disability. So we have to use the same principles of rehabilitation.
Interesting. So what is the purpose of pain?
Yeah. Basically, it's the alarm system of the body. Pain is installed in our body to protect us from danger. And it's a good alarm. It's good to have the alarm because people that have a deficiency, they don't feel pain. There is a rare hereditary disease that the person is born without the ability to feel pain. And so these people, they die at an early age because they can't protect themselves. So they don't know when they are in danger. So the purpose is basically to protect us from diseases, injury, traumas, from doing something really dangerous. and not only this, but also to alert when we have an infection, an inflammation, something that could threaten our life.
So are some people more susceptible to pain than others? More
Yeah,
sensitive to it?
when we talk about susceptibility, we're talking about a couple of different things. It's a pain tolerance, pain threshold. So pain threshold is how much the stimulus has to be to trigger the alarm. And pain tolerance is how much longer, how much time a person can tolerate a stimulus that is considered painful. There are changes. Even the same person has different thresholds and tolerance in different situations in their life, different time of the day, different depending on what's happening around them. We know in laboratory experiments, that you can manipulate that threshold and tolerance, like showing them different pictures, priming them to suffering. And because pain is not just a sensation of the body, but it's also an interpretation, how your brain interprets that as dangerous or not.
I like the interpretation piece. Let's go into that just a little bit. So, say for instance, when a person's in childbirth, they're supposedly in pain, but if they interpret as, oh, this is our bodies working together to get this child into the world and this is
Yeah.
natural,
Yeah.
they tend to do better than
Yeah.
if they just see it as pain. Is that what you're talking about? And how can we engage that for ourselves?
Yeah, that's one of the explanations. If the person interprets that childbirth has, it's going to go away, it's just a few hours, they still are going to feel pain,
Mhm.
but they are going to have a better memory of that event. It's not going to be so traumatizing. They may not have postpartum depression. They may have less anxiety around the issues. They may enjoy, and they will feel pain. Like the pain will be there. They will not be able to block the pain. They will feel, but they will suffer less. Yeah, so there are many mechanisms and therapies that are used, procedures with children, like children who have burns in their body and they have to do daily dressings. Those dressings hurt a lot. So you can use they use in hospitals here in Canada, virtual reality, like they put those glasses that the kid is seeing games or different things they're seeing in their, they're taking their attention away from the pain. And so the threshold and the tolerance to pain increases. So yeah, this field is fascinating. And the more I study, the more fascinated I am how we can modulate pain.
Are some people, I mean, what's the difference between acute pain and chronic pain? Let's go there.
Yeah, yes, because pain, so as I mentioned, pain is the alarm of the body, right? And it's the same thing as the alarm system of a house. So acute pain is when you have like a burn, you cut your finger, or you put your toe on the fire, or there is a toothache, or there is an appendicitis, something that just started and is damaging your body, is damaging the tissue, and it's putting your body at danger. So an infection and then or of inflammation in the tooth. So that's acute pain. And that would be similar to having a fire in the house. And so a fire in the house can damage the whole house and kill the person and the people inside. So that is similar. The other type of acute pain is so the first one, that is a lesion, an inflammation, we call this nociceptive pain. That's the technical name, nociceptive. The other type of pain is neuropathic pain, which is when there is a lesion in the nervous system that carries that information of pain to the brain. So the nerves, for example, we have nerves that bring sensations of our body, of our skin to the spinal cord, and then the spinal cord to the brain. So if there is any damage, lesion, disease in those nerves or the spinal cord, it can cause neuropathic pain. So that would be similar to the alarm system of the house having a short circuit somewhere. So the alarm can make noise and go, making the sirens can go crazy, but it just go there. Oh, it's there, the short circuit. Maybe you were opening the cupboard of your kitchen and the alarm was going off. And so that's neuropathic pain. That can also be acute pain or chronic. Now, chronic pain is when that either the acute pain continues, so there is ongoing damage, which is pretty rare because our body tends to heal very well. So if you have a burn and initially there is that pain, but your body will heal, will create a scar, and scars don't hurt. So 3 months later, 6 months later, a year later, 5 years later, 20 years later, you're not supposed to be feeling that pain from that injury, that cut that you had. But if the person continues feeling that pain, that becomes chronic pain, which means that the pain system, the alarm system is malfunctioning. So you don't call the fire truck, the police, the ambulance to fix because there's no more fire. There's no breaking in the house. It's just the alarm is kind of going off continuously. Nobody told the alarm system of the house that the fire was taken care. The house is not in danger. So chronic pain is the situation where the pain is not a signal that there is something damaging, disease, that you need to fix. you need to now fix the pain system, which is regulating the pain system.
So by the time you get chronic pain, what you're looking at is malfunction in the pain system, the
Yeah.
alert system, rather than the message that there's still something wrong with the body.
Yeah, of course, Gwilda, there are situations that the person still has an injury that keeps going on and on and on. And they may have even a mixed kind of pain. They may have acute and chronic pain, but most of the chronic pain is just it's a malfunctioning of the pain system.
Is there a psychological component to that?
Every pain has a psychological component, even acute pain. Even acute, we cannot separate the mind from the body. When people say, is this person inventing this pain? Are they creating this pain? Are they malingering? Are they, malingering pain might be, you can find some people that will create the pain for some purposes of gaining money or attention, but this is so rare. When the person says, I am in pain, they're really in pain. All pains are real. So we never call this, oh, this is a legitimate pain. This is a real pain. This is not real pain, because it is real. It's just, so the third type of pain that I mentioned to you is called nociplastic, because it comes from neuroplasticity in the pain system. It's real pain, because we can see with function MRIs and with some tests that even though the person feels pain here, but the problem is not here, we can see where the problem is, and it's in the pain system. So it is a real pain. It's just that the origin of the pain is in a different place.
Would that be like the phantom limb syndrome?
Yeah, good point. Yes. So phantom limb pain is an interesting phenomenon. It's a mix of neuropathic and nociplastic pain, because the person doesn't have the limb anymore, like they had an amputation of the foot, the hand. Mastectomy is considered phantom. If some people have mastectomy, like they remove the breasts and they have pain in the breast that doesn't exist anymore. Or tooth. Some people have wisdom tooth removal and they start having pain there. It's a phantom pain. It is because it's a reorganization of the pain system. So the pain system says, okay, I'm not receiving any information from that body part. What's going on? Where is it? I'm not receiving anything. That part disappeared. Nobody told me what's happening. So the brain starts creating that sensation to fill the empty space, because no neuron in the brain can go empty like do nothing. They all need a function. So they will create that. It's the same thing as tinnitus. Tinnitus is the same thing. Like the person will hear the zzz, the noise, but it's because they had a hearing loss. Those cells died. It's almost like an amputation of the hearing cells. And now the brain is creating that noise to fill the space.
Interesting. Well, it's time for a station break. Dr. Furlan and I will return very shortly, so don't go away. This is Mission Evolution, www.missionevolution.org. Does pain rule your life? With us this hour, discussing the complex issue of pain, is author of 8 Steps to Conquer Chronic Pain, A Doctor's Guide to Lifelong Relief, Dr. Andrea Furlan. Dr. Furlan, we were talking about amputations and teeth being pulled, and how when the limb or the tooth and all the nerves that are involved with it are gone, then the system tries to fill that empty space. Could you go into that a little more? I don't know that I totally get how it fills the empty space.
The brain will need to find a meaning for what's happening there. So it's all about interpretation. Pain is the brain trying to interpret what's going on. So because there's no sensations are coming from that body part because it has been amputated, the brain will then create a sensation. The brain will then make modifications and try to interpret what happened. Where is the sensation? And then the person will say, they will interpret this as pain. But they say it's a different kind of pain. It's not like pain that you feel if someone hits you. They will say it's hard to define. I feel the foot. I know the foot is not there. So one of the treatments for this is therapy that we do, mirror therapy. You put a mirror between their hands or their legs. So the eyes will see the mirror of the hand that it is not existing, it's amputated, but they will see, the eyes will see a mirror image of the limb that exists. So then the brain will say, okay, so this exists, and they're doing exercise, and then they're removing those sensations from the brain slowly, but it does work.
So do they remove the mirror?
Yeah, yeah,
Oh,
yeah.
interesting. So
So
it's kind of like recalibration, isn't it?
it's recalibration. Yeah, yeah.
Interesting. Okay. So why why does some pain end up being chronic pain,
Yeah,
and others don't?
yeah. It's more to do with the person that has pain than the pain itself, because we know the same injury affects two people very differently. And we know that whatever happened at the time of that injury, whatever happened to the previous memories that that person had with pain, their previous experiences with pain, also how the brain is primed to handle stress, because acute pain is very stressful. Like you feel that pain, that you don't know where it's coming from, what's wrong, I need to see a doctor. That's a stress. And so how the brain handles stress has a lot to do with, okay, this is very stressful, but this is acute. And then when the injury starts to heal, the brain has to stop those sensations of pain. But in people who are over worried about that, they don't know, or even the healthcare system around them is a disaster. Like one doctor says one thing, another one says another thing, you go to a third, and they get mixed messages. One says, oh, you do better, but the other one says, oh, this is horrible, look at your MRI, you're going to be debilitated for the rest of your life. So those mixed messages kind of prime the brain to be in the danger zone instead of focusing on healing. You see, you can move, your shoulder is healing well, you can start moving your shoulder. But if the person is overprotecting, then they don't. Again, the brain, the person is not fabricating it. This happens to you and me. We're not talking that the brain is doing this to trick the person. This is natural. This is the way we are all humans, and we all do this. Our brain is primed to protect us, protect the life, and it's always going to overprotect. You have to remember that. So if we don't break that cycle, if we don't look at the injury, ask your doctor and say, am I healing okay? Do you think that I'm healing okay? I did surgery for my knee and I had a lot of pain. It's very painful, but talk to the doctor. Do you think I'm healing fine? If the doctor says, I have no concerns about you, you didn't have any nerve injury, you can move your knee, you can exercise, please believe that and do the exercises. Keep trying to have a normal life, because that will send messages to the brain that you are healing.
The one thing I ran into with a lot of car accidents and this and that, where there's soft tissue injury, and the person then starts favoring that limb because of an actual acute injury, then other problems develop from that because they have this fear, I don't want to move it because I'll be in pain. Would you go into that a little bit? I've never understood how that exactly that works.
That is so common, Gwilda. That's so common. I see this. And of course, if you have, it's natural reaction, right? If you have a pain here, you're trying to protect, not to use it. And then you start using all the muscles around, and they have to work over time. And then we start having muscle pain. Muscle pain hurts a lot. It's unbelievable. We have muscles all over our body, and they really hurt like crazy. Sometimes they don't let you sleep. So then the person will then get more anxious, because now they injured here, but now they're having pain in other body parts, and my pain is spreading. And it can spread to become fibromyalgia, which is when fibromyalgia is a disease of pain all over the body, which is when this pain system is really out of whack and very deregulated. But before they become to fibromyalgia, the person start protecting, not using these body parts. And if they worry, I know what means to worry, because I am a warrior. And if we worry, then you contract the muscles even more, you're protecting even more, and then they can go downhill instead of recovering. So we do see a different trajectory in people who we call this, they tend to be pessimistic, catastrophizers, because they tend to go downhill. If you get someone who is optimistic, they say, no, I will do better, I can do it, my doctor told me that I'm healing okay. It's like the athletes, they heal faster. Even the healing process, the scars form faster because they are sending message that they can heal. And look at the athletes. Sometimes they even go back to their activities much sooner than they should, but in a sense, they feel that they can, and they actually can, and they heal. They do some things that is not seen in a lot of my patients with chronic pain.
So, interstage left, opioids.
Yeah.
What do opioids do with pain, and why are they so addictive?
They're wonderful. Okay, so let me say that I love, opioids are godsend because they are found in nature. The poppy plant produces morphine and codeine. So they had been used for thousands and thousands of years to alleviate suffering, to alleviate that pain. They are great for that pain that is more acute. Okay, so that pain that is, if someone just was in the war and they had an injury like a bullet that crossed their body, they are going to feel pain, and then they are going to need some relief. But that's for acute pain. It's amazing because it can even block completely the pain, cause some sedation. The person will be a little sleepy until they find, the care that they need, surgery, whatever will be doing to heal that injury. The problem is when we start treating chronic pain with these people, like you put someone who has like a back pain or fibromyalgia that is mostly nociplastic, that is a pain that the problem is in the pain system. It's not an injury. Although they feel pain here, the problem is not here. You're not going to fix here. You need to fix the pain system. We now know from a lot of laboratory scientific studies that if you give opioids to someone who has nociplastic pain, this pain of the malfunction of the pain system, you can make it worse because it's going to activate some receptors in the nerve system that provoke the amplification and chronification of pain. So we do need to be really careful if the person has only purely a nociplastic pain. If we need to give them opioids because they may have an acute, like a toothache or something, or surgery, it should be for a short period of time. So they are addictive because they make, opioids cause some changes in the way you feel, give some energy, euphoria, make someone sad, make them happy. If someone is depressed, make them less depressed. So who doesn't want that? So you take that pill, you feel like that. So that creates a pattern of tolerance and addiction, and that's when they start getting into trouble.
So, what's your take on the paranoia about opioids right now?
Yeah, I think they should be reserved for a short period of time for acute pain, either nociceptive or a neuropathic pain. For post-surgery, they can be used in situations where the pain is acutely very intense, but with a plan to stop. I think physicians need to start, but also have a plan to exit. The problem is a lot of people start opioids, but nobody is responsible for stopping. So these people keep getting renewals of prescription for months, years, and before you see, they had been on this for 20 years.
What are the physical ramifications of being on opioids for too long?
Yeah, so it has a lot of side effects. So they do cause sedation. So it may impair the person's ability to think, to make decisions, to have a quick judgment. It also impairs body functions, like the bowels become less active, so they have more constipation. Some people have nausea, and some people have also affect their hormones, like the testosterone is lower function, less testosterone in the body. They may also block the estrogen, so provoking osteoporosis in these people. And we know morphine, for example, impairs the immunological function, so they are more prone to infections. They can also cause sedation because they block the receptors in the brain that control the breathing. So these people stop breathing when they are sleeping. That's called sleep apnea. Yeah, so they are not without side effects. it has to be really, really taking, into considerations all of these things.
So you really need to understand pain to know what pain medication to use, don't
Yeah.
you?
Yes. Yeah.
Very
Make a right
interesting.
diagnosis. I think the first thing is to, not all pains are the same. They need to make the right diagnosis.
How much, and we're just about out of time in this segment, but how much does fear increase pain?
Every experiment that they tested this, if you put a person in an experimental laboratory, you're going to provoke pain. And believe it or not, there are volunteers that come to laboratory to be tested. If you show situations to them before that were fearful, movies, scenes, pictures, or you tell them something that is really sad, or even playing sad music. There are some types of music that make your brain to feel sad. They feel more pain. They will feel for the same intensity, because the scientists know exactly how much intensity they are applying in the same person. So the same person, they will say, oh, this is terrible. This is 10 out of 10. Now, if you change the color of the environment, like red color, they feel more pain. Blue color, they feel less pain.
Very,
And
very
it's a big
fascinating.
difference. We're not talking about a little tiny difference. It's a big difference. So if you change the colors of what they're seeing, the music they're listening, and what you tell them, for the same stimulation, they will say, oh, this is nothing. This is a little bit of pain.
Well, it's time for a station break. Dr. Furlan and I will be right back to continue our discussion. So you stay right there. This is Mission Evolution, www.missionevolution.org. Opioids. When does the cure become worse than the disease? This is Mission Evolution, missionevolution.org. With us discussing the opioid crisis is Dr. Andrea Furlan. Her website, drandreafurlan.com. Andrea, we've been discussing opioids and how useful they can be and also how much of a trap they can be. Um, when can you tell as an individual that you're going from the place of using opioids for chronic pain to becoming dependent on them? How can the individual kind of monitor that? Because apparently the doctors don't do it real well right now.
Yeah. So the signs of dependence are, so first of all, physical dependence happens to everyone who is on an opioid, but not only opioid. People can develop physical dependency even to blood pressure medication, to medication to reduce the acid in the stomach. So dependence is defined as your body needs that medication every day. And if you stop, or if you stop abruptly, or if you miss a dose, your body is going to ask and you are going to have withdrawals. Okay, so that's the definition of dependence. So basically, if you give opioids to a person every day, in about 2 weeks, 3 weeks, they will become dependent because the body will have withdrawals when you stop. But withdrawals is not the same thing as being addicted, or we now don't call addiction because there's a stigma around this name. We call this opioid use disorder because it is a medical disorder, it's a disease. It's not the person's fault. Addiction means, oh, you are an addict, it's your fault. No, it's a disease. So the person that develops tolerance and develop this dependence, they are more prone to develop an opioid use disorder because every time they try to stop, they have horrible side effects, like horrible withdrawals effects, right? They are going to sweat. The withdrawals from opioids look like a horrible flu, like you have stuffed nose, you have diarrhea, you have nausea, and you think you're going to die, and pain all over the body. So because they feel pain all over the body, they think, oh, I need that opioid because I have pain if I don't take it. But it's the lack of the opioid that is causing the withdrawals. So when they start getting into this pattern and they don't need the opioid anymore because their condition has healed, the problem that they had is gone, we have to tell them, you need to stop. Now, this person doesn't want to stop because they don't want to get the withdrawals. They would do anything to get that drug. that's when they go from a using the opioid for pain to someone who is now getting into trouble. They are now getting into this opioid use disorder. So they lose the control. They go to the pharmacy, get the bottle that was supposed to last for 2 months, and now they take everything in a month, or they take everything in 2 weeks. So they're using more than was prescribed, and when they run off, they get from the streets, or they borrow from friends, or they buy illicitly, and they would do crazy things, and they're always their life revolves into getting that pill. So that's why it's so disabling, because they stop working, they stop taking care of their family, they don't want to eat anymore. All they think is about, how am I going to get my next dose? So it's a transition. This takes sometimes weeks, months, or years. Nobody develops this from day to night. But we do need to be careful when we are seeing these patients to observe for those signals and signs that we are observing.
So the pain is real, but it's back to like losing a limb or something. Is
Yeah.
that correct?
Yeah.
Yeah. So, given that short-term use of opioids for chronic pain, for intense pain or acute pain, is very helpful, but you have to really monitor it and stop and shift to something else or some other method before the addiction starts.
Mm-hmm.
How can you tell that point, and what's the other thing you shift to?
Yeah, so when we realize the person is kind of losing control, they are using, some people, they tell me, it's interesting, I ask them, so are you using this for the pain that you had originally, that you, when the first time you got prescribed the opioid? They say, no, I'm using for all the pains. They're trying to treat the withdrawal pains. So then I teach them, I say, the pain that you're treating now with this pill is the withdrawal pain. And they, oh, okay, makes sense, because I know that pain starts coming at the end of the dose. So they start taking sooner, and they start, getting agitated before that pain comes. But the other signals that we also observe is that the person is using more than prescribed. They tell me, they say, doctor, if you don't prescribe to me, I'll have to buy this from the street. I say, well, do you know where you're going to find? And it's very expensive, and you never know what you're going to get. So then you see they are getting that pattern that they get desperate to get the drug. What do we do? So we did a randomized trial that was published last year in the JAMA, Journal of Medical Association, and the American Medical Association. And we randomized 604 people they were using opioids for years for chronic pain. And we randomized them to receive an education and support. And so to learn about these things. So what I'm explaining here to your audience is part of the package. And the other group, they didn't receive this special education. They just received some attention, but not the special education. And the group that was randomized to receive education, support, and a nurse that was helping them to reduce the dose, 1/3 stopped taking the opioids. 1/3 stopped completely. And most interesting is that the pain did not get worse, did not get better, but did not get worse. And then we need to start treating that pain, chronic pain, with the methods that we know work best, which is activating your life, exercising, mind-body therapies, some massage, relaxations, breathing, meditation, nutritional support, sleeping better, socializing. All those things are really how we treat chronic pain. And they did really well. But you have to see that 2/3 were not able to reduce, to stop the dose. But among those 2/3 that were not able to stop, 50% reduced the dose.
Oh, interesting.
So it was a good result, because we showed even for people who are long-term on opioids, we can do something with a little bit of education, support, and a little bit of coaching how to do it.
So you had a nice list there of things that you use. One thing that comes to mind is if you're in a lot, or at least perceiving you're in a lot of pain, how can you settle down enough to meditate? I mean, the pain, I would think, would interfere with that. How do you get from there to here?
Yeah. Yeah, we do have a lot of professionals here, fortunately, that help our patients to do this. It is not easy. I tell my patients, it's like living in a house where the alarm is going off all the time. Like you're feeling this pain constantly, all the time. And you are tired, you're fatigued. They tell me, I can't think anymore because this is so overwhelming. And then I tell them nobody can see because you look normal. And they said that's the worst part. I look normal. People look at me and they say, "How can you be in pain? Because you can do everything, and where is the problem?" So it's an invisible disability. There's that stigma that nobody can see. Even doctors, they say so much absurd to my patients. They say, "Oh, you must be inventing. This must be psychological. You need to lose weight. You just need to do some meditation and your pain will go away." No, that's not that easy. So the meditation, going back to your question, is not just for them to distract their brain and get distracted and the pain will get better. We need to, again, we need to fix that pain system. The disease is in the pain system. So how do you fix the alarm of your house that is going off all the time, making noise, waking up your neighbors, and you can't live in that house? You need to fix the alarm. So again, we use mind, meditation, somatic tracking. We use exercise to retrain the pain system. We do have a brain, in our brain, we have an inner pharmacy. I tell my patients, we need to open the doors of that inner pharmacy because you can produce your own opioids. They are called endorphins, enkephalins, dynorphins. But you need to activate your brain to produce those endorphins. So the meditation, exercise, nutrition, a good night of sleep, a good laugh, socializing with your friends and laughing produce endorphins. So we combine all of that because once the brain starts, okay, I'm not in danger. I don't need to fear this pain. I'm okay. The doctor told me that I can move. My knee is normal. It's okay. It's not normal, maybe proper for your age. Everybody has a little bit of arthritis here and there. So if you have arthritis in your spine, it's proper for your age. You should not be worried. It's not because you're old that you need to have pain. So again, do some stretches, but always with the intention to fix the pain system. That's the main change. We are working on fixing the pain system. And it's like magic. It takes a few weeks, sometimes months. But I discharge patients. Believe it or not, Gwilda, I discharge people. Actually, they come and discharge me. They say, "Dr. Furlan, I just came to say goodbye." I said, "Oh, really?" Yeah. They say, "I don't need you anymore. I have the tools to take care of me. I know what to do. I don't fear this pain anymore. I still have it here and there, but I'm doing the things that I enjoy. I'm traveling. I'm driving again. I'm taking care of my grandchildren. I am having fun, and this pain is not stopping me. And I don't need you anymore." That for me is the most rewarding part of my job.
I would imagine. I would imagine. So, a certain amount of discomfort is inherent in life. But from what you've been saying, it sounds like our attitude towards it is three-fourths of the battle.
Yeah. Yeah.
Interesting.
And it's hard for them because, again, when they feel pain, they are, everybody, we are born with this alarm in our body. When we feel pain, we immediately think something's wrong. I'm in danger. I need to eliminate that pain. But for chronic pain, you don't need to eliminate that pain because it's not a danger. It's by the only thinking differently. This is not dangerous. I'm okay. I'm not broken. I can do this. The danger signal, the alarm will start coming down. So you don't need to focus on bringing down the alarm. It will come automatically by you having a different approach.
So we have more control than we think.
Yeah, a lot more.
A lot more. So we're about out of time in this segment, but is the difficulty with pain sounds like a lot of it is not being educated, not understanding the function and how to work with it.
So you now know more than a lot of family doctors in Canada, and I don't know, maybe in the United States, because in family medicine, they are the ones, the primary care providers, nurse practitioners, family doc, they're the ones who see the majority of these people with chronic pain. I am a pain specialist. I work in a pain clinic. I'm not able to see everybody who has chronic pain because it affects 1 in 5 adults.
Well, we're going to have to pick up with that on the other side of
Yeah.
the station break.
So,
Please stay with us as Dr. Furlan and I continue to explore alternative treatments for pain. This is Mission Evolution, www.missionevolution.org. Is there more than pain that meets the eye? Can you actually control your own pain? This is Mission Evolution, missionevolution.org. We're continuing our discussion with Dr. Andrea Furlan. Her website, drandreafurlan.com. Dr. Andrea, we were talking about using alternative methods to pull yourself out of chronic pain. Can a person actually become pain-free using these methods, or is it more of a coping mechanism?
depends on the type of pain. Of course, if they have a pain that is more muscle pain, that is coming from, lack of exercises or shortened muscles or weakness or deconditioned, some alternative medicine techniques, like I am an acupuncturist. I do acupuncture, which acupuncture means you put needles in the skin and then it will stimulate the brain to produce endorphins, for example, and also muscle relaxants and endocannabinoids and serotonin and a lot of other dopamine. Massage also does a little bit of that. When you massage the muscles, you are sending impulses to the brain that will stimulate the brain to relax, to produce substances that are relaxing. But we don't want them to become dependent on someone doing acupuncture or massage because they cost money. You have to go. But I approve them. I say, if you need, go there, but don't become dependent. I like them to take more an active approach, the things that they can do for themselves, they can do at home. So if they learn things, I tell them, put the tools in your toolbox. You need a toolbox with the tools that work for you. So this can be for each person is different, depends on which kind of pain again. And they can become pain-free. They can become pain-free for a period of time or space out the episodes that they have pain, or they may, by doing those things, exercise, mind, body, good nutrition, good sleep, socializing, they can have long periods without pain. And then if the pain comes back, they know what is in the toolbox for them to take care of that episode.
So once you find what's in your toolbox, does it also give you clues as to what you're not doing that may be making the pain worse?
Yeah, they tell me all the time. They say, sometimes they come back to me, like years after, they come back to me and they say, well, I need to see you again. And they say, well, what were you doing that kept you away from me for 2 or 3 years? And they say, I was doing everything, but then I got lazy. I need a touch up. I need you to tell me if I need to modify my toolbox. And sometimes we need, like their condition may have changed or their disease may have deteriorated. They need something more. They need more investigations. But usually, if they know how it works and they can combine things like TENS machine, which is an electrical stimulation machine, they can apply to their own skin. They can do self-massage. I teach them how to do self-massage with a tennis ball, with a foam roller, and they can do these things at home.
It's nice to empower the individual, isn't it? What would you say if you could get into the office of all the doctors that actually see the patients all the time, your general practitioners, your preferred providers, that sort of thing? What advice would you give them about pain?
Mm-hmm. First of all, most important, pain is real. If your patient in front of you is telling you that they are in pain, and you ask them to give a number, for example, from 0 to 10, where 0 is no pain, 10 is the most unbearable pain. If they give you a high number, it means that they are suffering a lot from that pain. So believe in them, because I find a lot of medical professionals, they don't believe the patients because they can't see anything wrong. And the second thing is investigate what's going on. Is this pain nociceptive, which means there's something there for you to fix? Is this neuropathic, which is a nerve compression or a spinal cord or brain injury like a stroke, multiple sclerosis, a shingles, or this pain nociplastic? They need to learn about nociplastic pain. There is the science is there. We're not inventing it. I didn't invent this term. This was this term was coined by the International Association for the Study of Pain, IASP. It's an international group of scientists, clinicians. So there's no excuse. They do need to get a little bit of updated on the pain science, because again, a lot of people show up in medical offices with pain. It's the most common complaint that people go to the doctors.
Do you think that part of the opioid crisis and all the fear of getting people on opioids at this point is because the doctors haven't been given any alternatives?
Yeah, I think so. I think, and sometimes when they see these patients, like the patient sits in front of you in your office, and they're suffering. You can see that they're suffering. They say, I'm in pain, and they cry, they're depressed, their life is stopped, and we want to help. And it's so easy to give that prescription. Oh, here's a prescription of opioids for you. Take, 60 tablets and start taking this. Initially, the patient will get better. They say, oh, this is wonderful. Why nobody ever gave this to me? Why doctors want me to suffer not giving this to me? So initially, they will feel that euphoria, that pain will go away. But if you keep giving that medication, the body will become tolerant, dependent. They may get into troubles of addiction, or worse, they stop working for pain, because that's not treating the original pain. That is not treating the cause of the pain. They should do the other things, the lifestyle modifications, start exercising, or take other kinds of medication, antidepressants, anticonvulsants. But then who is going to stop that opioid? Who is brave enough to say, you know what, I think this is not helping you. Let's reduce the dose and stop. You create a lot of problems. There's a lot of resistance from patients who are taking these medications, and they really think it's helping them tremendously.
Psychologically, there's a fair amount of impact, it sounds like you were saying, because of the euphoria and this sort of thing. How
and
much
the
of a part?
withdrawals that they get when they miss a dose. Yeah.
So they, on one side, they're avoiding the withdrawals, and on the other side, they're seeking the euphoria. So that is that kind of like a psychological dependency as well?
It's very physical. Because the dependency is very physical. Of course, there is the psychological, emotional component. Like, we can't separate anything, but I would not call this a psychological dependency because it's very physical.
Okay. When we really understand pain, do you think it's going to change the face of how the medical system works?
I hope so. I am on a mission. I'm also on a mission. My mission is, my goal would be to teach everyone on this globe, and thank you so much for helping me to achieve my mission, about what is pain. What is pain, to understand pain. I didn't invent all of this. There's a lot of science behind this. Scientists trying to get this message out. And we do need to use media like this, because the public needs to know, understand, and we need to teach kids, because I think children in middle school should learn what is pain, what is the pain system, because everybody will develop pain in adulthood, and they need to know how to handle that, because it's very stressful. We now know too that people who have adversity during childhood, their mechanisms to fight pain, to fight stress, of resilience, are not well developed, because of all the stress that they had when the brain was being developed. We call this adverse childhood experiences. So then in adult life, they will have higher risk of developing chronic pain, fibromyalgia, substance use disorders, depression, anxiety, and even cardiovascular problems, and hypertension, and even cancer. So it creates a lot of problem. We do need to start teaching people in childhood.
Do you think that would keep a lot of people out of the cycle of getting addicted to opioids?
I think so. I really think so. Because if you teach them, if you give a child explanation of, what is pain, so when they grow up, they know the tools, how to handle pain, to get a good diagnosis. Don't stress too much. Your brain is trying to overprotect you. So it's going to sound the alarm. You're going to feel a lot of pain, especially if you are stressed, you don't know what's going on. But then you need to calm down. Once that injury has been healed, you do need to start taking, acting like normal again. Don't stay in bed. Don't do bed rest. unless, of course, if you need to, like if you have a fracture or something that the doctor tells you need to lie down, you do that. But if they don't, and then that that rethinking of what is pain, what is the meaning of pain, why would I need to use pain medications for a long time if I don't need it? So then don't even start. Or if you start, get a plan to stop. You start, but then what is my exit plan to stop taking this painkiller?
Sounds like it's an educational issue all the way around, isn't it?
I think so.
Yeah. So you mentioned some of your mission. Would you mind telling me more about what is your mission?
Yeah, because I think pain, I chose pain because it affects everybody. And in my mission, I like everyone to have this, for the people who suffer pain, which is all of us, to have a toolbox of what works for you. You do need to study your body. You can use some over-the-counter medications. Talk to your pharmacist about what they are, what they cause. Have some heat pads, ice packs, your self-massage tools, your TENS machine. I have all of this at home. And understand your body. Listen to your body, understand and have a good, understanding of what exercise does to you and how your mind works. That's for the person with pain. And then for the healthcare professionals who will see these people, they need to understand the science. They need to understand that in the last 50 years, there has been a lot of advances, but unfortunately, this is not taught in many medical schools, residency programs. They still lack this understanding. As I said, Gwilda, now you know more than a lot of GPs and family doctors. You can teach them because they never heard about these things. And for them, pain is pain, and they need to abolish pain and eliminate all pain. Some pains will not be able to eliminate, but we can live really well with them. There are a lot of interventions, injections, a lot of other procedures that we can do, surgery. They're not for everybody, but they do have a place, nerve blocks, in treating some of those chronic pain. So that's what I'd like to leave for your audience.
Well, it's a beautiful message, and I think it gives a lot of people hope, because if you're in chronic pain and you don't have any way of treating it outside of drugs, you're kind of in a trap. You're in a box. So there is hope, and thank you for bringing that hope to our audience.
You're very welcome.
Unfortunately, we are out of time, Dr. Furlan, so thank you so much for coming on the show.
Thank you for inviting me and helping me to achieve my mission.
My pleasure. Our guest this hour has been Dr. Andrea Furlan. Dr. Furlan is a physician, professor of medicine at the University of Toronto, and the author of 8 Steps to Conquer Chronic Pain, a doctor's guide to lifelong relief. To find out more about Dr. Furlan and where you can get her book and all she has to offer, visit her website, drandreafurlan.com. This has been Mission Evolution with Gwilda Wiyaka. For more information or to enjoy past archived episodes, visit our website, www.missionevolution.org. But please be sure to join me right here next time, as this mission will continue, bringing information, resources, and support to a rapidly evolving world.